the vascularity is present throughout the meniscus, even during 4 weeks of gestation. And it's not only in the 4 weeks of gestation, but even into childhood, even after birth, the vascularity is present throughout the meniscus. And as the child starts bearing weight, the vascularity becomes restricted to outer 1/3 of the meniscus. It's very interesting to note this. But sometimes the meniscus retains its original disc-shaped structure, and this is called discoid meniscus. There are two menisci pores, the lateral one called the lateral meniscus and the middle one called the middle meniscus. Okay, this is the schematic picture of the right knee. This is popliteus tendon here. The lateral meniscus is incomplete O-shaped. This is incomplete O-shaped, while the middle meniscus is C-shaped structure. This is C-shaped meniscus. Okay, and the lateral meniscus covers approximately 70% of the lateral tibial condyle. So this is proportionately more than the middle meniscus, because middle meniscus covers only 50% of the middle femoral condyle, tibial condyle. But the medial tibial condyle is bigger as compared to the lateral tibial condyle. But still, proportionately, the coverage area of the lateral meniscus is more, that is 70%. And the lateral meniscus is very loosely attached to the capsule, while the middle meniscus is firmly attached to the capsule. This is the capsule here, and this is firm attachment of the middle meniscus to the capsule. And the capsule is more thickened at around the middle portion, on the middle aspect of the tibia, and that becomes deep MCL. And especially to the deep MCL, the meniscus, middle meniscus is fixed. And there are other attachments called coronary ligament as well. So if you look at this picture, the middle meniscus is more firmly attached to the surrounding structure, thereby making it more vulnerable to the injury. It's firm, it resists some movement, so it's going to get more injured in case of isolated cases. But in contrast, on the lateral aspect, there is no fixation to the lateral collateral ligament. And another interesting factor to note here is the lateral meniscus is indented by the popliteus tendon. This is the popliteus tendon, this is the popliteus muscle, and this is indented here. So there is a small natural defect on the lateral meniscus on the outer third portion. But there are some aponeurotic expansions from this popliteus tendon into the lateral meniscus. So with the movement of the femur, the lateral meniscus is going to move, going to rotate with the rotation of the femur. And the root of the middle meniscus is fan-shaped. This is the fan-shaped root, while the root of the lateral meniscus is not fan-shaped. And this attaches quite anterior here at this portion. So it's very important to understand this anatomy, especially while we are making the entry portal for nailing. We don't want to violate the root of the middle meniscus, anterior root of the middle meniscus. And another important factor here is the anterior horn, anterior root of the lateral meniscus. It partially blends with the ACL. So while we are making tunnel for tibial tunnel for the ACL, we don't want to violate the root of the lateral meniscus, especially anterior root of the lateral meniscus. But when it comes to the posterior root of lateral or the middle meniscus, we don't need to worry about violating while we are making the PCL tunnel. There are only shiny white fibers on the middle meniscus posterior aspect, and which we don't need to worry about. Okay, and there is another ligament called meniscofemoral ligament. It actually arises from the posterior horn of the lateral meniscus and goes all the way to the lateral tibial condyle. So this meniscus moves with the movement of the lateral tibial condyle. And the significance of the meniscofemoral ligament is it acts as the anterior posterior stabilizer. And it also stabilizes the posterior cruciate ligaments. So when the PCL has been torn, the meniscofemoral ligament is going to stabilize the PCL, and it's going to allow better healing of the PCL because it stabilizes the torn PCL. And besides, this is the coronary ligament, this is the meniscus. This is also called meniscotibial ligament because it attaches the meniscus to the tibia, thereby stabilizing the meniscus. Since it's present all around like a crown, this is called coronary ligament, meaning crown-like. And this is the intermeniscal ligament. This is the fibrous band that connects the lateral meniscus to the middle meniscus on the horn part, anterior horn part. And this is present in 64% of the individual. And its exact function is unknown, but this has been believed to provide stability to both the lateral and the middle menisci. The vascularity, of course, is another interesting factor here. In childhood, the vascularity is present throughout the menisci. And as the individual starts bearing weight, the vascularity gets limited to outer 1/3 of the meniscus. This is the outer 1/3 portion, and this is the vascularity extending up to here. And the vascularity, these are branches of the genicular arteries, medial and lateral, superior and inferior, of course. And this is limited to outer 1/3. So how we exploit this knowledge? So if there is tear in the outer 1/3 portion of the meniscus, this has better healing potential. So we don't want to remove the meniscus when it's on the outer third, especially because it has better healing potential. We want to go for repairing the tear on the outer third of the meniscus. While the tear on the inner third is not going to do well, even if we repair it. So most of the times we have temptation to perform meniscectomy for tear in the inner third because it has very poor vascularity and it's not going to heal even if we repair. And accordingly, this has been divided into red zone, meaning more vascular, red-white zone. Some amount of vascularity is also extended up to the outer middle third of the meniscus, and there is almost no vascularity. This is called white-white zone. So how the white-white zone survives without vascularity? There are micropores on the meniscus surface, and in these micropores, because of mechanical pumping, the synovial fluid enters into the substance of the meniscus, thereby providing nutrition to the meniscus. So the white portion, that is the inner third, is going to get nutrition by mechanical pumping from the synovial fluid. So if we exercise, if we keep our joints mobile by jogging or games or whatever means, we're going to aid mechanical pumping of the synovial fluid into the meniscus, and the meniscus becomes healthy. It gets better nutrition. It applies not only to the meniscus, but also to the cartilages. And the biological augmentation, this is the concept that is done in meniscus repair. And this augmentation is done on the outer third while we are repairing the meniscus. Basically, the idea is to enrich the vascularity by stimulating angiogenesis. It may be with the help of the saber or with the help of a diamond rash, or even with a needle like trephination, making multiple holes on the vascular portion so that it stimulates angiogenesis and promotes healing. And this is the electron microscopy picture. This is the meniscus, outer portion, and this is pericapillary plexus. And there are few branches up to the red-white zone here, but the white zone doesn't contain any branches of the vascularity. There are three fibers, of course, the circumferential fibers. And it's again very interesting to note, the circumferential fibers are not present on the periphery only. These are also present on the middle third as well as on the inner third. And these are perforating fibers here, and radial fibers are also present. And these are radial fibers, and these are the circumferential fibers. And basically this meniscus is fibrocartilaginous structure, meaning it contains collagen as well as chondrocytes. And the most abundant collagen are type 1, but other collagens like 2, 3, 4, and other collagens are also present. But the majority is the type 1 collagen. And chondrocytes, these are the chondrocytes here. And as the patient starts bearing weight, as the individual starts bearing weight, the amount of collagen gradually increases up to 30 years, and then it becomes stable. And at around 80 years of age, the collagen content decreases and the corner sides again increase. This is the normal physiology of the meniscus. When an individual stands up, bears weight, then the weight is not transmitted not only to the cartilages, but also to the menisci. This is the menisci. So these equally are going to bear weight. So much so that 50% of the axial load gets transmitted to the menisci. So these are very important at full extension. While at 90-degree of flexion, this 85% of the axial load transmits through the meniscus. So when we are exercising in squat position, different exercises we perform in squat position, weightlifting, or several forms of sports, or walking upstairs, downstairs, then we are going to exert more load on the meniscus. That's 85% of the axial load, which is something more harmful for the meniscus. That's going to undergo wear and tear at a faster rate, which is something we don't want. So it not only acts as an effective shock absorber, but also it distributes synovial fluid. Let us imagine this meniscus is not present. Then the synovial fluid is not going to reach up to the femoral condyle, which is just above the meniscus. So it uniformly distributes the synovial fluid as well. And when an individual is bearing the weight transmitted radially up to the periphery. But these circumferential fibers, which are present more on the outer third, this is going to resist this axial load. Going to resist the axial load. So something wrong here. The meeting will end in 10 minutes. Okay. And, and in order to prevent this is called hoop stress. This is the barrel, which has a hoop on the outside. And if something is stored into the barrel, the bursting of the barrel is prevented by the hoop. These are the metallic hoops. So this has the name from this structure, and this is called hoop stress. This is prevented by the circumferential fibers. So we don't want to tear, we want to repair at least the outer third, or we want to preserve at least the outer third of the meniscus, because if you do not preserve the outer third of the meniscus, it is equivalent to not having meniscus as well. It is equivalent to total meniscectomy. So we don't want the total meniscectomy. We want the outer third of the meniscus, especially to prevent the hoop stress. Neuroanatomy is again very interesting. The nerve supply is more concentrated on the outer third, but there are some neural elements also present on the middle third, and that this is responsible for carrying pain sensation to the patient in the knee. And the mechanoreceptors, these are present more on the roots and the horns. These are more concentrated on the roots and the horns, and these are less on the body. And this has special significance because when the individual is flexing or extending, at the extremes of flexion and extension, the roots are going to sense because of the movement, because the movement occurs in the extremes of flexion. So the individual understands that my knee is undergoing extreme of knee flexion and I need to maintain my position. So that's called position sense, also called proprioception. So this is basically aided by the mechanoreceptors. So that's why again roots are important. So the roots are important not only for anchorage to the but also as a mechanoreceptors. Now this is the if you look at the tibial condyles, the anatomy is very interesting. Basically, because let us imagine a tibial condyle without meniscus. The meniscus has been removed. This is the lateral tibial condyle or lateral tibial plateau, and this is the medial tibial plateau. This is slightly convex, while the middle one is concave. So let's imagine a wheel on this structure. This is something like a wheel on a dome. Okay, and this is equivalent to femoral condyle. And there's a small portion that comes in contact with the lateral tibial condyle. While in case of the medial one, there a larger portion comes in contact with the this wheel. So if the lateral meniscus has been removed, the contact stress increases by 300%. So we don't want to remove the lateral meniscus. We want to preserve it or repair it as much as possible. That's because the result is convex and convex, that's the high amount of contact stress that's going to lead to wear and tear of the lateral tibial cartilages, which is very harmful. But in contrast, on the medial aspect, the cartilage is concave, so this is convex and concave. That is slightly less stress. So if medial meniscus is completely removed, then the contract stress increases by 100% in contrast to 300%. So it's not as harmful as compared to the lateral meniscus. So if you are supposed to remove, if you are supposed to choose one meniscus, imaginary condition, then the lateral seems to be more important. So the cartilage degeneration follows after meniscectomy because of this interesting biomechanics. And another interesting biomechanics is in flexion, there is anterior movement of the menisci. The lateral meniscus moves by 12.8 millimeters, while the middle one only by 7 millimeters. So there is more excursion of the lateral meniscus as compared to the middle one. And in spite of this little degree of movement, these are also considered secondary anterior-posterior stabilizers of the knee. Well, this is a very brief anatomy and biomechanics of the meniscus. If there are any questions, please drop them in the chat box. We'll be very happy to address the questions, not only from the presenter, but also from the panelists. Thank you very much.
The classification, the tears might be located in zone 1, 2, or 3. It might be in the posterior part of the body, mid body, or in the anterior part of the meniscus. And the tear patterns, these are a little bit more important to consider in our talk. These longitudinal, vertical, or horizontal, or radial, vertical flaps, or horizontal flaps. This might be the tear patterns, just as shown in the previous slide. And the quality of tissue is also very important. This might be, the tears might be because of non-degenerative injuries, acute injuries, or degenerative injuries, or might be some kind of undetermined type of tears. So in the Cooper classification, there is also zone 0, which is outside the the capsular junction region. And since it is just outside the meniscal tissue, we will just be talking about the meniscal injuries, not the tears that are outside the meniscal tissue per se. Just as Amit sir mentioned, in some proportion of the ACL tears, there is zone 0, the ramp lesions, which might lie just outside the posterior horn of the medial meniscus. So there is also another type of injury that we might come across. So in these tear patterns, as we can see, the longitudinal, vertical, radial tears and vertical flap tears, these usually are the acute tears in younger patients, which occur after some acute trauma to the knee. And in these cases, of course, if the patient is young and the tissue might not be degenerative type. And the Europeans, they had a consensus, and in this very nice paper, they have tried to differentiate these tears according to whether it is traumatic or whether it is degenerative type of tear. So the acute tears, the traumatic tears with which the younger patients come, these can be seen as meniscus tears, and the degenerative meniscus tears would be meniscus lesions. And logically, when we are trying to decide what to do with the meniscal tissue that is torn, the degenerative meniscal tissues will not be very much amenable to repair or to preserve. We have, of course, different methods to diagnose, starting from the relevant history, examination, and investigations. One of the examination techniques is McMurray's test, which is said to be of high sensitivity and specificity, but kind of limited accuracy, because as we have all felt at one time or the other, a little bit of difficulty in interpreting what we have found while doing the McMurray's test. So to increase the sensitivity and specificity, the authors, Lowry et al., they have uh, enumerated some criteria like history of locking and catching, pain upon hyperextension and hyperflexion, and palpation of the joint line. With positive McMurray test, this will lead us to the diagnosis of the meniscal injury. And among these, of course, the pain and palpating the joint line is also very important to, to come to a conclusion that the patient might have meniscal injury. In investigations, the MRIs show the meniscal injuries very well, and we should not be running around the higher resolution MRI pictures because the authors, different authors have found out that 1.5 Tesla resolution is as good as any newer high resolution MRI pictures to show us the needed lesion in the pictures. So when we come across these lesions, when we come across these tears, more than 30% of meniscus tears seem to be suitable for repair, but for some reason, less than 10% were also only were repaired. Why this mismatch? Why this mismatch? This might have some reasons behind this mismatch. For example, deciding sometimes is difficult while we go inside the joint and see, because it all starts from the patient, the history, the presenting factors, and what we find in the arthroscopy procedure itself. So why this mismatch is one of the reasons might be because if we do partial, subtotal, or even total meniscectomy, in the short term return to daily activities is faster, okay, and it is less costly also, and patient is relieved of pain, so he is kind of happier. But in contrast, if we do repairs, the rehab process is longer. There is still a chance of failure, which might want, in which case we might want to go for reoperative procedure, right? And of course, it's also costly, both in terms of time and resources, and time in the side of the patient as well as from the surgeon side. But the fact remains that the clinical success rate of meniscus repairs outweighs the failures by 85%. So we always should be trying to preserve the menisci. The other thing that we need to take into consideration is the time of presentation. So if the patient comes within 2 weeks and the repair is done, re-tear later would be only 6%. So if the repair is done after 2 weeks, the re-tear might be up to 20%. But within 3 months, even within 3 months, there is 91% success of the repaired tissue, shown by this author. So we come to a decision that preservation is the best that we have to offer to the patient. But what can be done according to the tissue that we have in hand is we might repair it, we might leave the smaller tears in situ. For example, tears less than 10 millimeters, especially in the lateral meniscus. And of course, if nothing can be done, we always have an option of partial meniscectomy. Of course, we have tools like last qualifiers, which gives us an idea of whether or not to go for repair. We straight away counsel the patient for resection. But as I already said, what we see clinically and what we find in the MRI might be a little different than what we actually find during the arthroscopy. Again, the smaller tear sizes, for example, less than 10 millimeter, can be left alone, and the tears of the middle menisci, they must be repaired. Again, this is related to what has already been discussed earlier with Dr. Sushil and Amit sir. So timing, I mentioned it briefly earlier also. So as early as possible is the mantra of repair of the meniscal injuries, and the age of the patient is also one of the factors. The younger at heart patients, the younger at heart patients might somehow present with these type of injuries, in which case, of course, you couldn't be able to preserve the meniscus. So less than 40 years of age, the patients have better outcome, which we always need to consider. Again, knee stability is another very important part that we need to consider. Uh, when the patients come with torn ACL, 57 to 80% of the patients have meniscus injury. And if the patient is with ACL injury, we cannot only repair the meniscus and leave the ACL or other ligaments just like that, because this will not give very good outcome in terms of healing. And one of the positive aspects of doing ACL and ACL reconstruction and the meniscal repair is that the bone marrow derived from the filling of the tunnels, etc., will also give kind of biological enhancement to the repairs, which will give in proper and well outcomes of the meniscus repair. So the biological techniques to enhance healing are the platelet-rich plasma, which can be done as a separate procedures. The stem cells, of course, this would be the part of drilling the tunnels or making holes in uh, the bone, or putting the blood clots separately, or using the fibrin glues. The other procedures would be needling of the meniscus tissue, which has also been discussed earlier, rasping of the meniscal tear, and opening of the medullary cavity. So these are the procedures that are shown in the pictures, putting of the blood clots as well as the rasping of the tears. And since we have this very excellent technique devised by Amistar and team, the outside-in repair of the longitudinal tears. Since we have techniques like these, then we should always be considering this as in our arsenal to counsel the patient and be ready to do this procedure to preserve the meniscus and to repair as much as tissue as possible. So to repair and to have the idea of what to do, for example, in medial meniscus, if it is in the posterior horn, all inside techniques would be done. In this portion, for example, inside out is the best modality, and in the outer portion of the meniscus, middle part of the body and the anterior horn, then we will be doing outside in techniques to repair the meniscus. And once it has been done, we might also want to assess about the meniscal healing. This is a picture of root tear. I haven't talked about the ramp and the root tears because they made it separate talk. We're just talking about the meniscal tissues per se. So meniscal healing assessment can be done. The arthroscopy would be the best method, but of course, the second look is not usually done for obvious reasons. And the second best option is the MRI. For example, in this picture, this is the 10-month gap between the repair and the reassessment. It has shown to be healed. The root has shown to be healed in the native position. The other the methods would be magnetic resonance arthrography if needed, or orthocomputed tomography if MRIs are contraindicated. If these methods are also with us, we can have proper management of meniscal repairs. In the rehab, there seems to be no one consensus. Some authors limit weight bearing for some time up to 6 weeks and then increase the range of motion over 6 to 7 weeks. At the other end of the spectrum, they give unrestricted room after few days of meniscal repair, and weight bearing as tolerated. But of course, we always have to go to the middle path and tailor the rehab procedures according to the patient's need and requirement. But they have shown that even in the elite athletes, 81% of the patients go back to their original level of activities and sports after meniscal repairs. So to take home the message, saving the meniscal tissue is very important, and prevention of osteoarthritis is what we are aiming for, and to restore the biomechanics. There are different methods of meniscal repairs which we must be familiar with, and one of the most important things is to have proper patient selection by age, whether they are chronic or not, the tears themselves, and associated joint instabilities. And always, as we have seen, proper counseling and is very much important to all the patients. Pre-procedures, post-procedures, during rehab, all these things are very important. So with this, I come to the end of my presentation. Thank you for bearing with me. If there are any questions, please.
Sushil, thank you very much, Nirdai. It was a wonderful organization of how to make decisions in meniscus tear. Any questions from the participants? Well,
there are no questions. I'll ask one question to NIRAB.
Yes, sir.
It is not a repair, but a little bit more practical thing, you know. I just took a class on osteoarthritis few weeks back, and arthroscopic debridement does not have any role in osteoarthritis, you know, arthroscopic lavage. But even in the American Association of Orthopedic Surgeons clinical practice guideline for osteoarthritis, they say that in some cases where you have osteoarthritis and there are refractory pains with a mechanical block, you should get a arthroscopic expert's opinion. What is your opinion on that? Did you come across any kind of, you know, latest information on helping us decide to do, you know, like a, you know, refractory pain in a osteoarthritic knee? Conservative means fail, and then you do a MRI and you see a meniscal tear. And how much are you going to counsel the patient for a meniscectomy? Did you come across anything new on that?
Actually, no, sir. In literature as such, I haven't come across that, sir. So I won't be able to answer very.
But I practically want to put this question to the forum. You know, most of the practicing arthroscopy surgeon might be doing, you know, meniscectomy in osteoarthritic knee. I think so. But even in the CPG of the American Association of Orthopedic Surgeons, you know, mechanical block in a osteoarthritic complex degenerative knee is an indication for arthroscopic intervention. how much do you counsel your patient? Can I have some opinion from the senior peoples, what they are doing?
What happens in the NHS is there was a time when debridement used to occur a lot in the NHS. Then there came a time then they said that no, because there's no evidence that in osteoarthritic debridement helps at all. And so the GPs, the PHCs stopped funding. There's no fund at all on that. And the only reason the hospital can give a good reason to do an arthroscopy is if there is a mechanical symptom. If there's a mechanical problem, you can do it. If there's no mechanical problem, better leave it alone.
So that is what I mean, that is an absolute indication. Even in the NHS, they say it like that. So what are we doing? What has been our experience? What if somebody comes with a mechanical obstruction in a osteoarthritic knee with a MRI proven complex tear, you do a arthroscopic meniscectomy, and how do you counsel the patient? Do you say that it's going to be completely cured?
No.
Or the pain is going to be there? Do you need to really, counsel?
We're buying time then. We just tell them we are buying time. You will need a replacement in future, and all we're doing is buying time.
Okay.
Okay. I think there are two issues, as the doctor said. One is the mechanical symptoms. If the patient has got a mechanical symptoms, in our practical practices, we have to convince the patient in a different way, because the patient will have a symptoms. So MRI is prescribed by almost every orthopedic surgeon in that situations. Because if you don't do, then the patient will go to another practicing surgeon and they will have the MRI done. And then MRI will show meniscus tear. And that becomes the bread and butter for us. Okay. Okay. So what I do is, like, if there are mechanical symptoms, as Dr. Sailas said, arthroscopy need to be done. But you should see clinically also if the patient has got the features of osteoarthritis, like there can be a patellofemoral osteoarthritis. The patient will have difficulty in climbing up and down in squatting position, and so might be tenderness in the joint line, medial, especially in the medial joint line. And so in that situations, the patient should be counseled that this mechanical symptoms will go, but the crepitus following the osteoarthritis may not go, or that can be some less to some extent in due course of time, once that the debrided part becomes smooth and so. And this is the way I do convince to the patients. I cannot say that doing any arthroscopic surgery and so that the patient will be asymptomatic and that lead to the symptom-free life rest of the life. And so.
Okay, thank you. I just wanted to bring this out. So let's if there are no questions on this topic.
Regarding the meniscectomy, shouldn't we be sure that the pain is out of the meniscus or it is out of the cartilages before we are going to intervene?
Yes, that is the problem. Yeah, we don't know. Osteoarthritic knee. Yeah, and it's not a that is what is my feeling. We are not going to cure the patient, but still practically a lot of us people, arthroscopic surgeon may be practicing, that, and I just wanted to know what was the opinion.
Sushil, in this issue, if the patient is having osteoarthritis for a long time, usually the onset of pain is like slow, and the patient is having on and off pain for a long time. If the patient is having acute pain with synovitis and effusion, this could be mostly because of some loose body effect. In that situation, I think the arthroscopy can help to some extent to the patient.
I think only the divert Bhairasa, but if you read meniscus repair procedure, osteoarthritis is clearly contraindication for doing any meniscal repair. So if you find that there is a grade 3 and above osteoarthritis according to the Kellgrens and Lawrence, so probably meniscal repair should not be done. So
we are talking an
meniscectomy.
Okay, yeah.
Osteoarthritis, I think only out of the way topic, but osteoarthritis patient, if they come to us, very rarely with the mechanical symptoms. This is mainly the pain. And Sushil probably was trying to say that from where this pain is coming is very, very important. If the pain is coming from meniscus, which is very unlikely, probably your arthroscopy is going to help. Otherwise, it's going to be a placebo. So in my hands, for last 4 years, I haven't done any arthroscopic lavage. If Ishwar sir agrees, so arthroscopic lavage is usually not done, because many of them, they come with the, yes, but arthroscopic lavage along with the unicompartmental osteoarthritis along with the STO is a compulsory procedure. So whenever you are attempting a high tibial osteotomy, we must do a arthroscopy, manage the cartilage and the meniscal lesion, and then do the high tibial osteotomy. Probably that is how the osteoarthritis.
And another thing, in my opinion, is like you have to distinguish the crepitus and locking of the knee. If the crepitus is there, most probably because of osteoarthritis, and the locking, to some extent, patient can be beneficial with arthroscopic partial meniscectomy.
Yeah, I was.
And one question I'd like to ask NIRAB, if the patient is having locked knee with a bucket anal tear and ACL tear comes after 2 weeks or so, then what do you do in that patient?
So
What does literature say?
In this case, sir, it is better to do both the procedures simultaneously in the same setting. If it is, if the patient comes in 2 weeks, which will be a very good timing for our setting. The meniscal tissue is amenable to repair mostly, and we have been doing that the same setting, sir.
But some people say like the patient can have arthropibrosis after that, or some people would like to do in a single stage both meniscus repair and ACL reconstruction at the same time.
Yes,
And
sir.
some people would like to do in 2 stages. The meniscus repair, have the gain the full range of movement and silent knee, and do the ACL reconstruction. It is bit like controversial issue, and that
Yes, sir.
differ with the surgeon's preference also. Right?
Exactly, sir. This is controversial, but better to do both the things in the same setting, because we don't want the patient to go around with repaired meniscus and thinking the pain has reduced, but with unstable knee, and go back and tear his repair. Sir. So it's better to do it in the, and we can go with the rehab a little bit slowly in these cases.
Yeah, I quite agree with NIRAB also, and also with Dr. Arjun, that there were people who used to say that it should be done separately. But nowadays, with passage of time where techniques have become more easier, where the main problem, I think, was if you are not versed, you might lose time, you might need more time to do a meniscus repair as well as ACL repair at the same time. But with your practice and with all the technical improvement, where you can repair the meniscus within less than half an hour and do a ACL in another half an hour, then we should be doing it. And there are also plus point that if you do a ACL and meniscus repair at the same time, that the chances of meniscal repair becoming successful is more there. I think this will come with time, but I do agree that there are people in the literature who say that meniscus repair should be done and then later on ACL, but with time, I think this will improve. So let us not, I think we should go to the last talk by Dr.
BIBEK,
BIBEK, okay?
Yes, sir.
And then, okay, BIBEK, over to you.
His topic is treatment options for meniscus injury. BIBEK, BASUKALA.
Thank you, Sushil. Thank you, Ishwar. So, is my slide visible?
Yes, BIBEK, please go on.
Thank you. Thank you, Arthroscopy Society of Nepal, for giving me this opportunity to present in this forum. So today I'll be talking about treatment options in meniscus injury. I'll be discussing right from excision to preservation of the meniscus. I am Dr. BIBEK BASUKALA. I work in AKB Center for Arthroscopy, Sports Injury, and regenerative medicine. So Bland Sutton in 1897 in his book called Ligaments, Their Nature and Morphology, he regarded meniscus as functionless remnant of intra-articular leg muscle. So because of all these misconceptions, there was an era of meniscectomy in early 19th century and early 20th century. And Smiley in 1967, he was a leading surgeon at that time, and he told something about the meniscus. He told that if it is torn, take it out, take it all out. Even if you just think it's torn, take it out. So this was the concept regarding the meniscus. This was the concept towards the meniscus at that time. It was used to be considered as a vestigial tissue, and if any problem, just take it out. So total meniscectomy used to be the treatment choice at the time. But nowadays, this is the era of meniscus preservation whenever there is possible, because this was because of work by McMurray, Fairbank, King, Krause, Barres, and Ahmed and Buck, who proved that meniscectomy is meniscectomy is not a procedure that is devoid of any complications, and the knees which had meniscectomy has bad prognosis than meniscus preserved knees. So this is an animation which shows that if there is weight bearing in the meniscus, in the knees which has preserved meniscus, what happens is the most of the weight is, or the load is absorbed by the meniscus because of its hoop stress, and that because of which the load is absorbed by the meniscus and less weight is transferred towards the tibia. So whenever there is meniscectomy, what happens is this hoop stress is gone, and the weight is more, the load is more concentrated towards that specific compartment, leading to osteoarthritis and leading to deformity. So meniscus biomechanics post-meniscectomy has been studied, and it has been shown that if there is total meniscectomy of the lateral medial meniscus, the contact area is decreased by 50 to 70%, and contact stress is increased up to 100%. Similarly, if there is total meniscectomy in lateral side, this decreases contract area by 40 to 50%, but stress increases by 200 to 300%. So these all increase in contact stress and decrease contact area is enough to deteriorate or damage the joint in future. So there are various meniscal procedures in meniscus injury. This can be classified into excision and preservation. Among the excision, what we do is meniscectomy. Better, we should better call it a partial meniscectomy. And in preservation, there is repair. In repair, there are multiple techniques according to the procedure, how we do it. It can be outside in, it can be inside out, or it can be all inside. Or most of the times, what we do is we combine all these techniques to preserve the meniscus. So decision making has already been covered by NIRAB, and many of these are important, but this classic picture of meniscal vascularity from Arnowski, which was done long back, the study of which was done long back, is still valid today. And the zone of meniscus, the type of tear, and age of the patients are most important factors that should be considered while repairing or while making the decision whether to preserve or excise the meniscus. So let us talk about the excision first, meniscectomy. So there are 7 golden rules has been proposed by Metcalfe way back in 1960s, and these all hold true till in today's date. What he mentions that we should remove all mobile fragments. We should not leave sudden change in rim contour, because if we leave the sudden change in rim contour, what happens is the moment patient starts weight bearing and having the twisting motions, what happens is the chance of meniscus injury is more. We should not try to obtain a perfectly smooth rim. We should not cut more meniscus to get the perfectly smooth rim, because small ragged meniscal margin may be remodeled in 6 to 8 months time. and we should preserve as more meniscus as possible. And we have to repeatedly probe the meniscus while doing meniscectomy to reevaluate the tear, whether the meniscus has been stabilized or not. And we should always try to protect at least the meniscus capsular junction, because this is very much important biomechanically. And we should use both manual and motorized instrument to have the perfect meniscectomy. So whenever in doubt whether to preserve or whether to cut the meniscus, in whenever in doubt, we should always incline towards preserving the meniscus. So steps of meniscectomy are, we should view from one portal and work from the another portal. We should always attack towards the posterior side first, and we should probe first, then cut the posterior horn first, posterior injury first. We should not completely cut the posterior side, then we have to cut the anterior part first, and then we have to grasp that meniscus, and with the help of grasper we have to gradually twist that meniscus so that the en masse meniscus is delivered outside. So this is shown in this video. First we are probed, then we gradually start cutting the posterior part, and then the anterior part is cut and it is debrided. Then the meniscus is removed with the help of the grasper. The posterior horn, which is more where the neural tissues are more concentrated, we have to make it more smooth and coagulate it so that there will be no pain in the future. So let us talk about repair, meniscal repair. I consider meniscus repair is more like a non-union surgery. We should have a good exposure. We should have good debridement of the edges so that they are freshened up. We should stimulate the vascularity, whether by opening of the vascular channels, the medullary cavity in fractures, or by trephination and various other techniques like low suction saving, or by using the various diamond rasp. We should stimulate the vascularity. Then we should have the good apposition of the ends of the meniscus tear, just like in fracture non-union surgery, and we should have good stable fixation, just like in surgery, non-union surgery we use plates and nails. In meniscus surgery we use good quality very strong sutures. So whenever required, we should always try to augment biology, like inserting PRP, inserting fibrin clot, or doing microfractures to augment the biology. So this corollary is very, very important while making while understanding the concept of meniscus repair. So let us get the video about the inside out repair. Inside out repair, as the name suggests, we throw a suture from inside and tie the knot outside. This is the inside out meniscus repair cannula. There are various zone specific cannulas available according to the manufacturing companies, and what we do is we insert this cannula, and these are the preloaded needles with the sutures, and 2 needles are available with the sutures interconnecting them. The cannula is inserted, and cannula also helps in reducing the torn meniscus. Then these needles are inserted where the bite has to be taken, and whether we can take both the longitudinal or horizontal type of suture with inside out technique, and this is very popular nowadays in many parts of the world. Only problem with inside out repair is this is more expensive than outside in, and these needles are taken out from outer aspect. If the inside out has to be done in more posterior part, safety incision is required, but in middle and anterior part, safety incision is almost not required. The needle is extracted from outside of the skin. Then the second bite is taken. Similarly, and we are trying to make a longitudinal type of suture configuration. So we are going out through the capsule. So The needle is again inserted, and we grasp that needle from outside again, and then finally we make a suture. So what happens is, in this inside out repair, when we tie the suture, the meniscus tries to move up, so the inferior torn margin tries to open up, so we have to always supplement this superior suture with the inferior similar suture in inside out repair. So we are deploying the inferior suture and inferior capsular sutures. So after doing these two sutures configuration, the meniscus sits perfectly. So another technique is the all inside technique. Sorry, this is all inside technique. What we do is, this is the bucket handle tear of medial meniscus, in which ACL is also turned. We do pie crusting of the medial superficial MCL so that the medial joint space is open. And what we do is we debride, we do all the procedures to increase the vascularity. So this is the fast fix from Smith and Nephew, where this is all inside, very popular instrument. What we do is we gauge the device gauge the device for a certain length, and we pierce the medial free end and go up to the capsule, and the as shown in the inset, the anchors are deployed and it is taken out. And while doing so, the sutures, the anchor is already deployed and it sits into the capsule, and along with this the sutures are taken out. Then another anchor is again deployed. In this video we are making the horizontal type of configuration of knot. Then this is constructed in such a manner that as we pull the knot, as we pull the thread, the knots are made, and we make these knot tight with the knot pusher, and then cut the knots with the knot cutter. So there are various techniques available. There are all inside out, and outside in. So as I have already mentioned during video demonstration of all inside, what happens is, as we make a suture, the inferior margin of the meniscus tear opens up. So always we have to supplement superior meniscus repair with the inferior meniscus repair so that the meniscal tear will be opposed with one another. Similar is true with the inside out, all inside repair. So what happens is, there is the need of more sutures, and more sutures mean more money. So these are the problem with all inside and outside in technique. For this problem, we devised, there is a technique in outside in, which our team has devised, and this has been inspired with this technique of circumferential compression stitch, where the two edges of meniscal tear is opposed. And the problem with this technique was it requires specialized instrument, and which are very expensive. Same problem with the all inside and inside out repair. So this is the demonstration of our technique, a video demonstration of our technique. What we do is, we use simple epidural needle. We pierce the medial half of the free end of the tear, and shuttle the Prolin suture. And with the help of Prolin suture, we shuttle the orthocord. Then we pass same 2E needle from inferior side of the meniscus, and again shuttle the orthocord. By doing so, what happens is, if we tie this, make this knot tight, there is circumferential compression of the whole of the meniscus. So this is the video, which is also available in arthroscopy techniques. This is the right side knee. We are doing almost all cases of meniscus repair. We do pie crusting because it increases ear space. And what we do is, we reprobe so that the extent of tear can be measured. And this is probing. So the extent of meniscus tear, all types of meniscus tear has been examined. So what we do next is we take out all the loose flaps that are present in medial or central or peripheral flaps. And next step is the biology enhancement. We can do low suction shaving so that the edges are abraded, the pericapsular tissues are abraded, so that vascularity will be increases. The diamond rasp shaving is done to augment the vascularity. Now we insert the cannula for good suture manipulation from the anterolateral portal, and we now insert the 18 gauge 2V needle, and it comes from superior aspect of the meniscus, central flap of the meniscus, and it pierces the inner free flap of the meniscus from superior to inferior. Then from where the epidural needle inserts, we make a poke, we make a sharp poke, and we make we insert, we make a soft tissue tunnel with the help of mosquito up to the capsule. Then then we insert the proline, number 1 proline, through this cannula, through this 2V needle, and we grasp this proline and take out through the anteromedial portal through the cannula. Then we shuttle our suture, that is number 2 orthocord, with the help of this proline. So we can see the orthocord is being shuttled through the meniscus. It is going right from inferior edge of the inferior surface of the medial free flap of the meniscus and going out to the capsule. The second bite of the epidural needle is through the inferior surface of the meniscus. The number 1 proline is again inserted. It is taken out through the cannula. The same orthocord, or the other end of the orthocord, is now shuttled with the help of simple knot out to the same soft tissue space. So while we pull this thread, we can see that the circumferential stitch has been taken. We are pulling the second thread, and while doing so, the circumferential stitch, the circumferential compression has been taken. And what we finally do is we make a SMC sliding knot outside, and we slide it. The post is being pulled, and it sits right up to the capsule, so that there will be circumferential compression between the 2 flaps of the meniscus. So we are doing same circumference, same good compression within the in between 2 flaps of meniscus, which were being done with the 2 different sutures in inside out and outside, all inside technique. So this is the final repair. Very good opposition, very good compression. So this was published in Arthroscopy Techniques, and this same video is available to be seen free of cost in Arthroscopy Technique site. So we were awarded with ISSN Research Awards 2020 for this same technique. And there are newer advances in meniscus surgeries like polyurethane meniscal homologs and meniscal transplantation, which are not available in our country at present. So take home message is very clear. Many things has been studied and many things have been said about the importance of meniscus. So save the meniscus must be the take home message of my talk. Thank you so much. Thank you for patient hearing.
Thank you very much, BIBEK, for such an elaborative presentation. And again, once again, congratulations for the award. I don't see any questions in the chat box here.
Dr. Sushil?
Yes, sir.
Okay. Thank you, Dr. BIBEK. Your presentation is always very much illustrative and very much clear. Congratulations.
Thank you, sir.
And regarding the for the newcomers like young surgeons, what do you suggest the clear indication for meniscus repair and the meniscectomy, partial meniscectomy?
Sir, as I've already mentioned in my talk, the age is very important. Age, that is the physiological age and activity level of the patient. And the location of the tear, if it is in white zone, very small, very thin tear, then it's good that we excise it. Otherwise, if it is in red or red white zone, it's better to be repaired. And younger age, the location of the tear in red or red white zone, and then the longitudinal, purely longitudinal tear without any complexity, and the acute tears, the tears, acute tears where there is no signs of chronicity like noodling and irreducibility. These are the tears I think we have to repair. Otherwise, they have to be excised.
How do you decide whether it is acute or chronic? Like it's by duration or looking at the characteristic of meniscus arthroscopically and so?
Sir, acute and chronic basically is defined according to the time duration. But our problem in our the problem in our part of the world is the patient one present to us in acute stage. Many of them present in very late. But and what we do is we decide whether to do meniscectomy or meniscus repair on table, on arthroscopy, after arthroscopy. Because if the meniscus is reducible very easily, there is no stress at all. And if the medial is the two flaps, flaps, the torn flaps are easily opposable, and there is no rounding, because there is no rounding. And if the field is not that firm, then they can be repaired. Otherwise, they are good to be excised.
I am asking you because this is the era of preserving meniscus. It's even Dr. NIRAB also mentioned about the role of meniscus in prevention of osteoarthritis of the knee.
Yes, sir.
So we'd like to repair conserve the meniscus most of the time if possible.
Yes.
And so in some literature they say like if the meniscus is degenerative, complex degenerative, and if there is a flap tear, and if it is longitudinal one and it is not reducible, then only you need to excise.
Yes.
And otherwise, age is the relative indication and contraindication, because most important is the physiological age.
Yes.
And the duration also, even after 3 months also, they have achieved very good results up to 90-91% and so.
Yes, sir.
And so,
I would like to add something, sir. I think Ishwar sir, Amit sir, and Mani will agree on this. While talking this talk, I tried to see the meniscectomy videos for the bucket handle tear, and I could find very little. Most of the bucket handle, most of the longitudinal tear, whatever the duration of the tear, we try to repair it in our center. So, and as for, we have not done relook arthroscopy or re-MRIs, but many of these patients, almost all of these patients are asymptomatic because of in meniscus. So I think meniscus repair can be, the duration, time duration is just a number. If the meniscus can be well opposed and there is no signs of noodling or there is no signs of chronicity in two edges of the meniscal flaps, then they have to be repaired. Yes, sir.
I just wanted to add, it's time is not a factor nowadays. Age is also not a factor. That was also repeated by Dr. Arjun. Expert people now say, like Charlie Brown, when we went to the Pune, what they say is, even if there are, even after your repair, if you do not find healing of the tear, but if your reconstruction of your repair technique is so robust to hold the torn part aligned, it does not matter whether it unites or not, but if you can hold your torn parts together with your reconstruction very robustly, that is why, you know, by the outside, even in the inside out technique by Charlie Brown, they are using more than, you know, 50, 60 sutures to repair the torn meniscus, so that even if it does not heal and the anatomy, at least the anatomy, near normal anatomy of the meniscus can be reconstructed, that will go a long way of preventing osteoarthritis. So nowadays, as everybody knows, it is the era of preserving meniscus. It does not matter whether the chronicity is there or even age, but we have to repair or reconstruct the meniscus. Doesn't matter even if it does not heal. If it can be opposed by a robust construction, then it should be done. And it depends upon a lot of things, you know, like in the West, people are still doing all inside technique, but I tell you that in the literature, they report that about 20% failure in all inside technique. They still say that the inside out is the golden standard, but that is why Charlie Browns are doing the inside out. For our center, you know, we are trying to devise a technique that is very cheap. You know, that is also robust. You know, we are using more than 6, 7, 8 repair in a maybe a half of the longitudinal tear of the middle meniscus. It has to be seen, you know, in the future, and what we have published, what has been accepted by the international audience, also our technique, you know, it has to be seen also. We have to prove that outside in technique as is also a robust technique to at least not heal, but reconstruct or repair the torn meniscus, I would say.
Vivek?
Yes, sir.
Yeah. While doing outside in technique, you make a soft tissue tunnel, isn't so?
Yes, sir.
How many soft tissue tunnel do you make? Like with a very small prick-like pole, you cannot make bring all the sutures through that. Do you make a sometime vertical incision also? Like, how do you avoid injury to saphenous nerve also? Sometimes this is said one of the common complications is the nerve injury on the medial side.
Sir, what we do in our procedure is we make a poke with the 11 number knife with which we make our regular portals. We make a small poke, then we take a sharp mosquito and poke it from that point, and then we open it right up to the capsule. So by doing so, from same poke, we can take 1, 2, or up to 2 or 3 sutures. The one posterior poke will be helpful to make 3 sutures posteriorly, and one slight anterior poke will be helpful to make 2 or 3 threads, 2 or 3 sutures anteriorly. So maximum we have, I think we have done. Maximum is 3 or 4 pokes. Otherwise, we just get away with 2 pokes usually.
But I do make one vertical small incision like 2-3 centimeter and so. Then I do mobilize subcutaneously, and that will help to avoid the saphenous nerve around there also. Then all the sutures are pulled through that only.
I think this technique was devised by Amit sir. I think he can shed some light in this technique. Amit sir.
Number of the soft tissue tunnel doesn't matter. What matters is how easily you can approach the inside of the meniscus. Saphenous nerve is not a concern if you just give a nick into the skin, and then you do a soft tissue dilation. If you see the video, we do not go up to the capsule with the blade. So we just give a nick into the incision. We take a small mosquito and make a soft tissue tunnel. And so far in 230, so probably there is no issue of saphenous nerve entrapment or injury.
Okay.
Sailash sir wanted to ask something, I think. Sailash sir. Yes, sir.
It's really nice to see your video and everything, and I'm sure you've got lovely mentors who've been guiding you. I just wanted to put across is once you do chronic cases, old repairs, do you consider putting in clots or growth factors? How much have you all been using them? I don't have much of experience on that, but wanted to know your team's experience.
Yes, sir. If we do meniscus repair along with the ACL reconstruction, we generally do not use any augmentation like fibrin clot and all, sir. PRPs, fibrin clot and all. But we usually do the microfractures over the lateral femoral condyle, the anterior part of the lateral femoral condyle, to augment the biology. Sometimes we have even used the fibrin clot, and even we have inserted the PRP clot with the help of thrombin serum. We have inserted the PRP in between the two flaps when the repair is for isolated meniscus injury. For meniscus injury along with the ACL reconstruction, we never do it. For isolated, we do augment. We always augment with microfractures, but in some cases where we think that this is very chronic and the repair is healing will be a problem, then we insert the fibrin clot and other things as well.
Can I add here?
How much of blood do you take
yes,
for
sir?
your clot?
Yes, sir.
How much of blood do you take? Suppose you are putting in a clot, so how much of blood do you take? You're taking blood from the periphery.
Yes, yes, sir. We take the 20 to 30 ml of blood, sir.
How much blood do you have to take and to make the clot?
20 to 30 ml, sir. We let it clot and we insert that clot in it. It is not so easy technique. It is a difficult one. The clot remains, clot starts displacing once insert into the joint. Yes, sir.
Yeah, yes, sir. As I just wanted to add, if some patient who are very demanding and they have a isolated, meniscal tear, we can counsel them on using a PRP with this thrombotic agent, that is available, but that is a little bit expensive. You get some patient who really want to be, get a very good confidence on him to, they want you to repair that. In that case, we can counsel and tell them that there will be an added cost of that PRP with that thrombotin agent, and that has shown to quite help in healing of the meniscus, isolated meniscus tear. And in few patients who were very demanding, we have told them that we can use that, but that is going to cost a little bit more, 20,000-25,000 more. And if they are willing, we can try that. Regarding that thrombin platelet clot, thrombin clot, that doesn't take that much money. You need just the blood and the clotting. That was being done, but I think with the PRP and the thrombotic agent, that they have a better chance of being getting healing done. So you can counsel the patient, and it's going to cost a little bit more.
Vivek, one question for you. It's a general question.
Yes, Sushil.
For the newcomers, we have just gone through a certain period of training and we are very good at triangulation. When do you suggest them to start the meniscus repair?
See, this is very tricky question. So everybody starts with diagnostic first, then simple procedures like meniscectomy, then ACL. Then I think once you are confident in doing the ACL reconstruction, once you start doing good meniscectomy, and once you can triangulate every instrument in every corner of the knee joint, then you are good to do repair. And you should have good assistant as well, because meniscal repair, you need good assistance, you need good positioning of the limb, you need good valgus, and you need that catcher of the thread. That thread has to be manipulated from the other side. So you should train a good assistant along with you if you are planning to do good meniscal repair, I think.
Is there any tips for the beginners for meniscus surgeries? It may be meniscectomy in the difficult sites, or it may be meniscus repair.
Sushil, can I add in? Yeah.
Yes, sir.
Yeah, you tell. I'll give you my experience. Like the standard meniscal repair we have, is being done now at our center with a more standard technique. What I learned to do a meniscus repair was, even before we were perfect, I was perfect in doing ACL reconstruction. There were few cases where I did a outside in, just general, putting a suture, not that technical thing. But what I mean to say is that you should start with small repairs, and of course your technical expertise is needed, but you have to jump to that pond to make that decision. It's a very difficult thing. Of course, opinions vary. I would say, like you must be versed with what you want to do, and of course you must have a patient that is believing on you also. You must get the patient's confidence, so that even if your first try fails, there are chances that meniscal repair might fail. It is not 100%. So you must have your patient's belief and confidence on you, and tell that I will do this repair, I will do for the best of your benefit. But even then it fails. So it's a technically, for me, my experience is a technically difficult thing to say when to start doing meniscal repair. Regarding meniscectomy, like it's one of the, that is why I asked that first question, how many of us started doing, meniscal surgery, directly repair, we were doing meniscectomy in the beginning, and that was usually the osteoarthritic meniscectomies, and then you start your arthroscopic skill with putting your needle, putting your scope in a osteoarthritic knee first. That is the fact. I tell you frankly. And then you later on do it. So there are a lot of things to consider. I don't think there is a place where you can say that. Of course, you have to have your seniors to tell you. You have somebody who you can believe on, somebody who can teach you. And give you a helping suggestion. It's a very difficult question. Yeah. Yeah, Sushil is very quiet today. You can add in also.
Sushil, can I add? Can I add a bit? You
Sure,
see,
sir.
if you go to current literature says that um, from 60 to 80% of the ACL tear will have concomitant meniscal tear. And out of these 80%, almost 60% will have a bucket handle tear of the medial meniscus. So my request to all the youngsters, before you embark on learning ACL, probably you must learn at the same time the meniscal repair as well. Here comes, I do all the things in single setting, Arvind सरले अघि भन्नुभएको चिजलाई अलिकति amalgamate गर्ने हो नि, because to me meniscal repair will take more time than the ACL reconstruction. So about 45 minutes for ACL meniscal repair, and then about 25 minutes for the ACL reconstruction. So this is very important. So if you, for the beginners, if the time is little longer, probably you try a repair of the meniscus in first stage. You wait for some time, another 6 weeks, guarded mobilization, guarded exercises, and take the patient after 6 weeks for ACL reconstruction. By that, doing that, you will learn how to do a meniscal repair and you will learn how to do a ACL. So what happens most of the time? You take the patient for ACL reconstruction, you find out a meniscal tear. Meniscal tear will take you 1 hour or 1.5 hours. You don't have time to reconstruct the ACL. That is why most of the people, most of our youngsters, what they do, they take out the meniscus. So probably you may need to counsel in your beginning of your career, explain your patient that it may go into 2 stages and do it there. So there is no point, if you do a complete excision of the meniscus and you do a ACL reconstruction, especially if it is a medial meniscus, bucket handle tear, your ACL is going to be lax because your bony stability is not there, your meniscus is not providing stability. Your ACL is going to be lax, your ACL is going to fail, and the osteoarthritis is going to set in. So with the current information coming up with the meniscus, we have to make all the efforts to preserve the meniscus. So we preserve the meniscus. If you can do it in single setting, very good. If you cannot do in single setting, probably schedule for a 2 setting. Yes. If you use all inside, it is not difficult. Even you just click, click, 2 clicks, and your meniscus is done. But if you learn Smith and Nephew's, official report of the fast fix, the 40% failure rate of the fast fix. So even in the expert hand, 40% failure of the fast fix. So each fast fix in Nepal will cost you 33,000 Nepali currency. So now you can just imagine if you waste one fast fix, it is a 33,000. So cost is an issue, and probably all inside technique, inside out technique and the outside in technique, these are the two techniques that is with us in hand, which is really cost effective. And I'll really encourage all our youngsters to learn these two techniques. If they don't like outside in technique, inside out technique is good enough. Why inside out technique is more popular than outside in technique is because of inside out technique is company driven. If you remember that earlier, there used to be a free needle in which you can, stitch in or pass in your sutures. Now they have taken that out. They don't give free needle. Now the needle are attached with the suture. So each 2 needle and 1 suture for one knot of the meniscus. That will cost you about 11,000 rupees in Nepali currency at this moment. So if you can do outside in technique, it is not that difficult. You can give an incision, you can do without an incision, but learn how to do a meniscal repair during your training. Wherever you go, just learning a ACL reconstruction is not enough. We must learn and we must teach our junior how to do a meniscal repair as well.
Fair enough, sir. So this stresses the importance of the clinical examination and history taking, of course, and proper MRI interpretation before we embark on the ACL reconstruction.
Yes, and Sushil, one thing is these all techniques, all inside out, all inside and outside, and these are not devoid of complications. The all inside techniques, the multiple neurovascular injuries has been reported in literature. Even inside out techniques, if we venture in posterior horns of medial or lateral meniscus, if we do not give safety incisions, there is every chance of the vascular injuries. Even in outside in injuries, if we venture more posteriorly, there is a chance of neurovascular injuries. And another problem with outside in technique is we can make the articular cartilage injury, the articular cartilage scuffing and all is very common. So it is not as easy as it seems in the videos, because I think good dedication to learn these techniques under good mentor is the must before we venture to do in the live patients. So I think that is the suggestion I would like to give as a new beginner in this technique to our new other colleagues.
Okay.
Thank you very much, Bibek.
Yeah, thanks Bibek, Sushil, Amit, everybody. It was a nice discussion. Do you have any more? Does anybody have any opinion, comments? There are none, now that we have spent 2 hours together, it's very cold inside the room, we want to go out today, Saturday in the sun, So if there are no further discussions, further comments, I think, thank you all of the participants. We had nearly 20-25 people in the beginning, but still 20. Nothing, no comments, nothing. We call it a day. Thank you, Sailas. Thank you, Bibek, and the speakers, Dr. NIRAB and Sushil.
Thank you, sir.
For a very nice presentation. Let's keep it up. This is very nice. We came back after the festive season. Christmas is there. New Year is there. It's been nearly a year with the COVID,
COVID year.
Yeah, stay safe.
Stay safe. Thank you. We will come back again, maybe in a week or more time. Thank you all for joining in. All the
Okay, thank you. Thank you. Thank you. Bye-bye.
Yes, sir.
Thank you so much.
Thank you, sir.
Bye.
Stay safe all.
Bye. Thanks, Vivek. Yeah.
Thank you, Sailas sir. Thank you, Amit sir, for saving me. There was technical.
Thank you, Vivek, for all your running around virtually.
Thank you, Nirav bhai.